So let's start with the neonatal things. This is a classic, and I think if you get a film like this in your exam, you should be very, very excited because you can completely nail this one. So this is a case of Vateral. It's a neonate. You know it's a neonate because you've got this clip there of the umbilicus. Now then, what's going on up here? This is a nasogastric tube which has been passed, but rather than it coming down the middle into the stomach as you would expect it to, it's coiled up in the esophagus. Oops. The reason for that is because there is a proximal esophageal atretic pouch. So this is esophageal atresia. Now, as I'm sure as you're aware, there's esophageal atresia and there's also esophageal fistulas. And if there's a fistula, then you should expect to see gas below the diaphragm. And if there's an absence of below the diaphragm, then you know it's a type 1 or type 2 fistula, but there's gas here below the diaphragm. So we know that there's an esophageal atresia. And if you look through the spine, look at that level there, that's wrong as well. So these are multiple vertebral segmentation anomalies. That's how we would phrase it. And if you look at this rib here, you see how the rib is funny? It's because the rib at that level follows the vertebrae, and that vertebrae is abnormal. So that's why the rib looks hypoplastic and gracile. So you've got an esophageal atresia, you've got multiple vertebral segmentation anomalies. This is the classical appearance of a Vateral. And if you look really, really carefully just up here, there was another tube just adjacent to the nasogastric tube. And you see this has got a dashed line. You know it's not an endotracheal tube because an endotracheal tube should have a continuous line, but this has got a dashed line. And that's something called a replogal tube. And that's used for secretions in the proximal atretic pouch. So if you see a case like this, you should confidently tell the examiner that it's the case of Vateral. This is just a reminder of all the things that Vateral stands for. This is an acronym. This is the acronym broken down for you. And once you've described all of your findings, hopefully very confidently, you should recommend that the patient needs an echocardiogram. That's because in here, you can't really tell what's going on in terms of the cardiac anatomy, so they need an echocardiogram to better delineate that. Also an abdominal ultrasound, because they are prone to renal abnormalities in particular, and a referral to paediatric surgery, because this is not going to fix itself. They need a surgical referral and ultimately an operation to correct the abnormality. So that's just a nice, easy warm-up for you. That should be relatively straightforward. Now then, what's going on here? This is a case of exomphalus major, to be precise. You've got an enormous there is that you've got a covering. With gastrocystis, you've got bowel loops that are free floating and they're not covered by a membrane. Here there's a membrane covering it. That's how you know it's exomphalus. And the size of it would make exomphalus major. And major is when there's a defect of more than 5 centimeters. Now, if you look in here, there's lots of different densities. Here, this is definitely some loops of bowel. They look a bit dilated. But what's this? You've got this increased density here, and this is almost certainly liver. And if you think about it, all of the vessels would have come through the abdominal defect into this hernial sac supplying this liver. And the danger is that the herniated viscera can tort on a vascular pedicle. So this needs a careful abdominal ultrasound to see exactly what's going on in here. And I've seen quite a few cases where there is one liver, or sometimes not liver, one kidney, or sometimes 2 kidneys herniated into here. So they need quite a careful abdominal ultrasound to tease out exactly what's going on here. So this is a case of exomphalus major, and it's major because of the defect, which is more than 5 centimeters. As I say, they need an abdominal ultrasound. Major carries a worse prognosis. Why is that? Because they are associated with chromosome abnormalities, which is different to gastrocystis. So if you see gastrocystis, it's bad, but not as bad as exomphalus major. In gastrocystis, the defect is right paramedian, and they have a much better prognosis. And if I just take you back to the film here, if you look down here, this is the nasogastric tube going in, and look, it's going into this defect. So you've got herniated stomach in here. So this is quite a morbid diagnosis and needs quite careful surgical management. So this is a case of exomphalus major. Just want to demonstrate that to you. Now then, this is a case of a congenital diaphragmatic hernia. The other differentials for this would be something like a CPAM, and I'll go into the differentials in a little bit. Let's talk through the lines and tubes, because as you know, whenever you're faced with any case, and particularly in peds, we're paranoid about it in peds, you have to focus on the lines and tubes first. So let's go through them one by one. This one is the endotracheal tube. You can see the beveled edge there, and actually it's really low. This is the carina here, right main bronchus, left main bronchus. So the ET tube is low, that's number one. Now you've got this thing here. This is the nasogastric tube. Down, down, down as you expect, but now it's doing a loop towards the head. So that's telling us that there is stomach herniated into the chest. And this, if you see this, then this absolutely nails the diagnosis of CDH. You've got two lines here, which you can't really see all of. Anatomically speaking, you would expect the UAC to be on the left-hand side because the aorta is on the left. It's probably the UAC, this is probably the UVC. We can't be absolutely certain, but you should at least comment on their presence and try to determine what they are as best as you are able to, bearing in mind that you haven't got the whole of the line visualized. The reason why I've got this film is not because this is a difficult diagnosis, because it's not really. I wanted to draw attention to this, and these are lines that you don't see that commonly. This child is on ECMO, which is extracorporeal membranous oxygenation. The reason for that is because this is such a massive defect. It's having significant mass effects on the mediastinum, so therefore it's compressing the heart and also the lungs. So this lung is really, really hypoplastic and therefore is not very good for gas exchange. So in real life, this case was picked up antenatally because they saw that the defect was so large. They were planned cesarean section and to come over to Great Ormond Street for ECMO while they were being worked up for their surgical management. This line here is the arterial cannula, and this sits in the common carotid. And this is the venous catheter. This is in the internal jugular vein, and it sits here in the right atrium. You can see these things here, these are the side holes. You need really fast flows through ECMO cannulae. So that's why the lumens are so big, and that's why I've got these massive side holes. So just to recap lines and tubes, ET tube, nasogastric tube with the tip in the stomach, and the stomach is herniated into the left chest. This is CDH. This is the arterial catheter, and this is the venous catheter for ECMO. And this is a relatively common procedure, certainly in tertiary hospitals. And when it's a known diagnosis of CDH antenatally, and they are put on this because they have impaired gas exchange and impaired cardiac function as well. As I said, differentials for this is a CPAM. The way you can tease that out is to do an ultrasound of the chest. If you put the probe on this child's chest and you see bowel loops, peristalsis in real time, that tells you that it's a CDH, job done. Whereas if it's a CPAM, then the bowel won't be there and obviously you won't see any peristalsis. So that's how you can use the ultrasound to distinguish between the two. And those are the main diagnoses, CDH or CPAM, if you see these bowel lucencies within the hemithorax. These children need to be referred to cardiothoracic surgery for further management. That's a little brief whistle-stop tour through the neonatal pathologies. Let's dig a little bit into some common musculoskeletal things. Something that we see quite a lot of is developmental dysplasia of the hips, also known as DDH for short. And in this particular case, there's obviously some asymmetry here, but let's dig a little bit deeper to see if we can put some objectivity into why this film is abnormal. This is a busy slide, but just bear with me. I've drawn lots of lines. Actually, come off a little bit. This line here, this is Perkins' line. And it is, the alignment is off, that's a bit of a shame. It's supposed to be a perpendicular line, a vertical line, which just cuts through the edge of the acetabulum, just there, that's where it should be, and also on that side. So this is Perkins' line. And then you've got Hilgenriger's line. And if I go back to the previous slide, you've got this thing here, which is the triradiate cartilage. It's non-ossified in young children. As you remember from your embryology, the hip bone is actually made of 3 bones, and then they fuse in late childhood / early adolescence. So this is the triradiate cartilage, and Hilgenriger's line is a horizontal line drawn through both of the triradiate cartilages on both sides. So you drop your line through there, and then you can draw Perkins' line, which is perpendicular to it. And as I said, it should just skirt through the edge of the acetabulum. And then you've got this thing called the acetabular index. So you drop a line, as I've demonstrated here, along here and along here. And if it's normal, then this should be less than 30 degrees. This should be less than 30 degrees. So this is the normal side. And take my word for it, this angle measures less than 30 degrees. And the other is that if it's completely normal, you want the capital femoral epiphysis on the normal side to sit in this lower inner quadrant. So there's a line there, there's a line there, splitting this area into quadrants. 1, 2, 3. You want it to be in the lower inner quadrant. So if migrated and it goes to the upper outer quadrant, then you know it's abnormal. And also, when you draw your acetabular index, then this angle is more than 30 degrees. Then again, that adds weight to your diagnosis of it being a developmentally dysplastic hip. What do these children need? They need an orthopedic referral. This can also be diagnosed on ultrasound. And in fact, ultrasound would be the first port of call if the baby check when they're at first born is abnormal and they've got clicky hips. Then you would do an ultrasound scan, or you would refer them for an ultrasound scan at 6 weeks' time. So serial ultrasound scans if it's abnormal, and then if it's persistently abnormal, then they will go into a Paediatric harness. These are things not necessarily that you'd expect to quote in your exam, but just know that they can be diagnosed on ultrasound initially, and they need an orthopedic referral. And if it's really, really bad, then they have an osteotomy plus or minus a hip spica. But as I say, these are more advanced orthopedic procedures. Now, I just wanted to throw them in there to let you know that they are out there, but the main thing you need to say is that they need an orthopedic referral. Hopefully that's clear. This is just to show you what happens further down the line. This child was initially diagnosed at 2 months. This is the abnormal side. You can see the capital femoral epiphysis is smaller. This is the normal side. And you see this is quite shallow. This angle here, it's tending more towards the vertical than it is towards the horizontal. So there it is, very small. And then on the other side, it's starting to catch up. And also it's more convincingly within joint now. So they can be managed very effectively with a Paediatric harness, as this child was. So this is a 6-year-old with left hip pain, and there's an abnormality on the right-hand side. Any takers as to what this might represent? This is your chance to be interactive. It's a bit strange sitting in my house, not looking at anybody, not being able to hear anybody, so work with me. If you have an idea what this might represent, then pop something on the chat. Let's see if anyone's alive. Oh, very good, very good. Like it, Waleed, good work. Definitely a Perthes, definitely a Perthes. So this capital femoral epiphysis it's small, it's reduced in its craniocaudal height, it's sclerotic. Look how dense this is compared to the other side. There's also fragmentation there as well. This is Perthes, also known as idiopathic avascular necrosis of the capital femoral epiphysis. And this is a good age for Perthes as well, actually. Now, let's just give you a bit more background just to cement some of the radiological appearances. Commonly happens in children between 4 and 8 years, boys more so than girls. They can present with hip pain, but also knee pain. It can be referred pain. So if the examiner throws into knee pain, but they give you hip radiograph, just bear in mind that it could be because of referred pain. These are subchondral lucencies that I was referring to. And it's widening of the joint space. Look at that space there compared to that space there. It's definitely wide. As it gets more advanced, you get sclerosis and the flattening, as I have described. Again, these patients need orthopedic referral. Bed rest helps with the symptoms. Conservative things like simple analgesic paracetamol can be helpful as well. And if it's really bad and they've got an impaired gait, then they'll need osteotomies to contain that femoral head because it's at risk of drifting out, and then they'll have earlier onset arthritis.